So yeah, no problem. So last week I worked with a slide deck that your prof had posted, and the second night, so I do this on Sunday nights and then again on Monday nights with like it's just a different set of students from your class. And I ended up doing like a mind map, and they really, really appreciated it. And I know that there was somebody in this group last week who had asked if there was anything like more visual instead of, you know, just a bunch of words that we could look at. And so I ended up making a mind map. I posted it, so if you want to take a look at it for inflammation especially, I think it's really helpful. It's the same information as the PowerPoints. You don't need to go through both. Just pick whichever one, you know, you feel like you can learn better from and go with that. I think the mind map one, especially for inflammation, might be a little bit better, just to, it kind of shows you how everything connects. It's just so much information. OA or osteoarthritis shouldn't be too heavy. It's a little bit of a lighter week all around, which is awesome. So we should be able to get through it fairly quickly. And then if you guys have any questions, you can let me know. So one of the things that like will come up in NCLEX prep is knowing the difference between like osteoarthritis and rheumatoid arthritis. So we'll go through that a little bit later. I don't know that it was in your notes, but it's definitely something you should know and will help in the future. So basically, osteoarthritis is a progressive, quote unquote, non-inflammatory disorder of the synovial joints. There's already a spelling mistake, sorry. So when we say non-inflammatory, we're talking about osteoarthritis. What it actually means is that the etiology of the disease is not inflammatory. In other words, it didn't start based on inflammation. It didn't start with inflammation. It starts with a progressive breaking down of this articular cartilage, which we'll talk about. And then from there, your inflammatory system probably may or may not kick in, and then you will have inflammation. So it's not that you won't have any inflammation when you have osteoarthritis. It's that it begins with this progressive destruction on its own. So that's a really big difference, because I can never say that word, rheumatoid arthritis is exactly the opposite. It begins, it's autoimmune, so it begins with inflammation. And so those are that's one way that we can tell right away pathologically whether we're dealing with osteoarthritis or rheumatoid arthritis. So basically this if you see the words progressive, degenerative, slow onset, long term, you know that we're talking about osteoarthritis. So what we're talking about is this, I just want to make sure, sorry, I lost my pen here. There it is. So what we're talking about is this cartilage right here, this articular cartilage. And what it is just like this smooth kind of cartilaginous tissue that coats the outside of the bones at the joint, so where they meet. And really what it does is it provides like a smooth, lubricated surface that's low friction, so that when the bones are moving around and moving together inside of the joint, they're not grinding on each other, right? It's a way to make the joint move much more smoothly and protect the bone underneath. So osteoarthritis, in osteoarthritis, that articular cartilage is what's breaking down. That's the thing that's degrading and wearing out, and then causing some remodeling and so on. And we'll go through that in a minute. The etiology of osteoarthritis. So the primary osteoarthritis, and you know that like primary or idiopathic it's on its own. It wasn't caused by another disease. Secondary is it's caused by something else. So when somebody has idiopathic osteoarthritis, we really don't know what it is that's causing that. There's really isn't evidence one way or the other. Secondary osteoarthritis can be caused by a number of things, and there's a nice little list here for you. But really, what it is anything that is going to put like pressure and wear and tear on this cartilage and on the joints. So things like mechanical stress from, say, a sport, trauma, inactivity, so the opposite, obesity, because of just the amount of weight that putting pressure on. That's especially true for your knee joints. Congenital abnormalities, so you can just be born with something, right? So if you look kind of over here to this, it's really just talking about how, so a lot of people will have one or two of these things and never develop osteoarthritis. So it's kind of like a conglomeration of different things. So you may have mechanical stress, but maybe you're just not predisposed to osteoarthritis, so you won't get it. But so it's just, this whole thing is really just identifying that it's a little bit more complicated than just, you have one or two of these things, so you're going to get osteoarthritis. I just wanted to, before I go up, I broke down the word for you. Just, I find this to be helpful, and I don't know if it helps you guys. Anytime you see osteo, we're talking about bone. Anytime you see arthro or arthri or whatever, we're talking about the joints. And of course, itis, we know, means inflammation or swelling. Does not necessarily mean infection, just means inflammation or swelling. So osteoarthritis obviously is swelling of the joints and bone. Like legitimately, we don't, the bones don't swell, but that's the best kind of all-encompassing name for it. So the good thing about, I was talking to the other class that I work with, and they were saying like breaking down these words is really helping them. And I think it's really important, because if you run up against a word in an exam, and you guys are all experienced, you've seen osteoarthritis, you've seen inflammation and infection, but you might not necessarily recognize what they're talking about on an exam, because they'll use like a different phrase or some word that you're not used to. So if you can learn to recognize those little pieces of the words, you can kind of like find a way to figure out what the word means, even if you don't know. So that's why I'm kind of doing that. I think it's helpful. The most common places that osteoarthritis exists or that are affected are your spine, hip, hands, feet, and knees. This is pretty common sense. These are like your big joints. I've never seen anyone come and have osteoarthritis of the elbow. There are other problems that happen there, but these are kind of your typical joints where you find osteoarthritis. So what's happening in osteoarthritis? So this picture here is like a normal joint. So you can see the articular cartilage protecting the bone. Then if you move over here to this B here, this is where the the cartilage has started to break down, and it can form these like little cracks in the cartilage. So this would like crack here and crack here, almost like dry skin, like it just cracks. Eventually it will break down. Those cracks can become large crevices, and eventually they will go down all the way to the bone. Normally, your body can repair damage to the bone. I mean, we all know you can break a bone and your body actually repairs it. This here, isn't necessarily like a part of your notes. I just kind of wanted to show you, because this is what's causing a lot of the problem, is that normally when something is destroyed, for example, your articular cartilage, your body has this process of healing it. So you have this hematoma that forms, and then this fibrous tissue, and eventually you have complete bone remodeling, where you've got this, yes, it'll be weaker, but your bone has been repaired, and they're actual like osteophytes, like bone cells that are replaced. It's actually really incredible. So as these this articular cartilage is getting is being destroyed, it's cracking, it's breaking down, your body will try to repair it. Unfortunately, it can't really keep up with the rate of degradation, and so the structure of what's replacing that damaged cartilage changes. It's not as strong as it should be. It starts to erode. It's thinner and softer than it should be, and so you end up with this kind of decreased range of motion. And these, I lost my spot. And these osteophytes, there they are. Osteophytes are really key to understanding a lot of this. So eventually you end up with, basically, if you look here, you basically end up with no cartilage between your joint, between the bones. And little pieces of that cartilage has maybe broken off, maybe little pieces of the bones are chipping off, and your body is working at trying to remodel or fix it. And what's happening is it's forming what's called these little osteophytes, or these little kind of bone growths. So it's really your body that's attempting to fix what's going on, but it ends up creating these little like osteophytes. I don't know if I have a better picture than this. And that can actually end up looking like these kind of like little knobs. You can see it from the outside on someone's hand. If you look here at this picture of hands, one of the really common places for these osteophytes to form is on the distal interphalangeal joint. So before we go further, I'm just going to, in general, when we're talking like describing where something is on the body, you're always talking in relation to, okay, I am not an artist, and I'm also drawing like with the mouse pad, so it's really hard. So we're always talking about where something is in relation to like the core of your body, okay? So it's a little bit more complicated with organs and stuff, but for what we're talking about, as we move, so let's say we have something here and we have something here. We would describe this as proximal or near, right? And we would describe this as distal, distal. So when we're looking at the hand, you just imagine which one comes on the way away from the body, which comes first. So you have these, really, I mean, these two interphalangeal joints, because I think these are considered metacarpal joints, but you have these two interphalangeal joints, which is basically in the phalange, right? So this joint is the proximal joint, and this joint is the distal joint because it's further away. Okay, so these osteophytes tend to form either on the distal or proximal interphalangeal joints in the hands. When they're on the distal, which is the further one, we call them Heberden's. When they're on the proximal joint, we call it a Bouchards nodule. That's really the only difference between them, is where they are on the body. From the outside, it just looks like kind of a large bump, like a swollen disfigurement. You've all seen people with very, very arthritic hands with little bumps, and they're sore. That's what those are. Those are those osteophytes. So one of the other ways, one of the ways your body is going to respond to, especially to those little pieces of cartilage that are breaking off in here, in your synovial cavity. So you remember that if we look over here, just really quick, you've got like bone and bone. If you look here, you have like a cavity kind of in between. Actually, it's maybe easier to see here, right? Where the synovial fluid is, that's keeping the joint kind of lubricated. And so you've got those little chips of cartilage and maybe even a little bit of bone that are chipping off, and kind of imagine them floating around in this surface. Well, immediately the body sees those as like a foreign object, right? And so you remember from last week, we talked about what happens in the how the inflammatory response deals with that. So you can have this like secondary inflammation, and they're calling it secondary synovitis because it's the synovial kind of joint capsule that swells, right, or that becomes inflamed. But it's because of those little chips. The phagocytes are coming in and engulfing or trying to, fight against or whatever those foreign bodies. But if you remember, those original kind of inflammatory markers that are released, so you have the same inflammatory markers as before. You would have your histamine, your bradykinin, all of that are calling. They're going to call these white blood cells to the joint, and that's why you end up with that secondary inflammatory response, and the prostaglandin and bradykinin will cause pain and so on. Okay, so again, it's not that osteoarthritis doesn't involve inflammation at all. It's just that it started back here with this mechanical degeneration. It didn't start with the inflammation. Let me just see here. So I think we'll go this way. So clinical manifestations are pretty obvious. You won't have any problems identifying on a test. Obviously, you have joint pain. You can have fairly mild, and sometimes it can be very, very significant. I've seen people who can barely move, like their pain is so bad, and this limited range of motion can really affect people's lives. Sometimes that joint pain, depending on where it is, it can kind of radiate to the groin or the butt or thigh or knee. And then in very advanced cases, you get this crepitation, which I believe, you know what, I should have looked it up, but I believe it's that kind of like that crackling, cracky sound. You can actually hear it. But if somebody wants to look that up just to make sure, so we can have a good definition of crepitation, I'd appreciate it, because I don't want to lead you guys wrong. And just maybe throw it into the chat and we'll deal with it. So this joint pain in osteoarthritis is obviously it's going to get worse when you use it. So you get up, you walk around, the joint becomes more sore. Your number one really treatment is to rest, and it's really about finding that balance between resting and movement. It'll often get worse sometimes worse at night, and will wake people up. It's that painful. And then you've heard people say, oh, I know that it's about to rain because my knees are bothering me or whatever. It actually does. It is affected by barometric pressure. So that cool and rainy weather does affect that pain. And then specifically, it can be very difficult in more progressive cases where like sitting and rising from a chair can be quite difficult. It's often very stiff in the morning, should resolve within about 30 minutes. And that's one of the things as well. If you look kind of down here, there's this little chart I put in for you, just highlighting the difference between osteoarthritis and arthritis. So osteoarthritis, it's gonna start quite a bit later. This is This is autoimmune, so it's going to start earlier in life. This is degenerative, so it's going to take years and years for it to build up to the point where you actually feel it, right? Again, the onset is slow, whereas rheumatoid arthritis can come on fairly quickly. When I say quickly, I mean it will come on in a matter of a few months. This is a really big thing. So when you see unilateral pain or joint problems, so if it starts on one side, it's usually a good indication that we're looking at osteoarthritis, because in rheumatoid arthritis, that problem is systemic, and so it's going to hit those joints at relatively around the same time. So you're going to end up having polyarticular pain, which means pain or stiffness in a number of different joints. So you may get it in both knees or both ankles or what have you. This is a big thing too, is osteoarthritis. It gets worse when you use the joint, and that's because it's grinding together without that articular cartilage there. Whereas rheumatoid arthritis is an inflammatory problem, and so it actually can sometimes get better because when you move it, because you're increasing blood flow. And then you really shouldn't have other symptoms with osteoarthritis. This, again, rheumatoid arthritis, because it's autoimmune, you're going to have other symptoms that come along with it. So this is super important to know for NCLEX for sure. It may be important as well for your exam. I just want to not skip these up here. So we were talking about kind of these osteophytes, Herberdin's nodes and Bouchards nodes. There's a couple of things that happen specifically with knee OA, where you have these joint malalignments. The bow-legged is a little bit more, I see it more common personally. We call that a varus, and then the opposite where the legs are leaning in like this, that would be valgus. These are both common kind of malalignments that will occur, but will sometimes occur with OA. And then this is really interesting, that somebody with OA on let's say one hip, that joint space, because of that cartilage that's lost, that kind of joint space becomes smaller, so their one leg actually will be shorter than the other. I mean, it won't be a huge difference, but it will be one shorter than the other. So if you come across a question, that's a fairly decent sign that there's OA in the hip. Can be about a million other things as well, but for this test, go with OA. And then we have this kind of, as with every other disease, we have this kind of grading system. And unfortunately, you basically just have to memorize it. There's not a whole, it does make sense. Grade 1, you have minimal clinical symptoms, very little damage seen on the x-ray. You might see a little bit of softening on an arthroscopy, and maybe they might do a lavage, although I don't think that would be something I would think we would do a little bit later, when the pain has become difficult to live with, right? So here now we have some mild symptoms. This is stage 2 now. Now you're seeing this decreased joint space. And then and the fibrillation, which I took a little picture of here. If you look, it's kind of like this kind of that is the fibrillation of the cartilage or the bone. So you would see that on an arthroscopy. And then, what they would do is go in and do a lavage, which basically is just they go in and they kind of wash away the debris. And from what we talked about earlier, we know that if we can get rid of some of that debris, some of those little bone chips that are there, we're going to stop. We should be able to stop this kind of inflammatory reaction from happening, or at least slow it down. Stage 3, you would have moderate symptoms. Now you have your osteophyte formation. So this is something I would remember for, like, highlight for an exam, is that when the osteophytes start to form, we're talking stage 3 or grade 3. Fragmentation, so when they actually start to break off, the pieces are starting to really break off. That would be part of stage 3 as well, and then they would go in and do debridement or resurfacing, which is just like mechanically smoothing out the surface. Then stage 4, you have severe clinical symptoms. This is where you would get that malalignment, and then eburnation, which is, everything, it wears it down to the point where it's so smooth. You can look here. These pictures here are kind of like the articular cartilage at stage 1, stage 2, stage 3, and then stage 4. If you look here, you can see like fibrillation. Here too, you can see some of that fibrillation. And then this is kind of right here. Sorry, is kind of the sorry, I can't draw there. The eburnation, like that shiny, slippery kind of parts. Sorry. And then at that point, there's not a whole lot we can do other than, there's definitely things in all of these grades that we can do to help relieve the symptoms. But in terms of like fixing the problem, at that point, we're talking about really like a knee or a hip replacement. We talked about that already. So let's swing over to, I think I have some stuff on diagnostics. There it is. So again, when we're talking about osteoarthritis, just like when I said here, it will develop at an older age. That's because that destruction will begin earlier, but you don't actually have, so it starts cracking a little bit here and there, but you're not going to get symptoms until you're quite a bit older, usually into your 60s. Postmenopausal women are at a higher risk because of their decreased estrogen levels. This would be a great question for an exam, so just keep that in the back of your mind. So how do we diagnose osteoarthritis? Usually it's a matter of doing, a history. Patient comes in, they tell you like, oh, I've had this pain. You do a physical exam. And then the big thing is to do a bone scan or a CT scan or possibly an MRI. You would be able to see the joint space narrowing, the hardening. That's just what sclerosis is, just like the hardening of that cartilage. And then you would be able to see osteophytes if we were at that stage already. You wouldn't see anything in the blood work really unless the inflammation has become so high, and again, that's kind of secondary inflammation, has become so high that your ESR may go up. And if you remember, I don't know if we went over this in your inflammatory thing. I'm getting my classes mixed up now, but an ESR is it's called an erythrocyte sedimentation rate. So it's, if you break up the word, erythro is red blood and cyte is cell, and we're looking at the sedimentation rate. Basically what they do is they take your blood, put it into a test tube, and then, it's more complicated, but they wait for those erythrocytes, the red blood cells, to kind of settle in the bottom of the test tube. Usually that happens fairly slowly because red blood cells are buoyant and they don't aggregate or stick together unless there are cytokines or other acute phase reactants in there with them. Those cytokines will weight down the red blood cells. So it's a really good way to tell if the inflammation has gotten, or how much inflammation is in there. Inflammation is one of those things that's really hard to it has a lot of different markers, I guess. So it's hard to like say for sure, yes, this is, this is an inflammatory problem. Again, you can have an inflammation that's causing a problem, or you can have inflammation as a result of a problem. But the only time when we're talking about osteoarthritis that you would see that increase in your erythrocyte sedimentation rate is during acute synovitis. So that secondary response that we looked at over here, sorry, over here, has caused that inflammation, and now there's so many cytokines that you would have an increased sedimentation rate. They do pull synovial fluid out of a joint, and this is mostly just looking for an infection or gout, right? It would be, we want that to be clear or clearish yellow. We don't want it to be any other color. Those are great questions that pop up on exams all the time. I mean, so this is something, I'm not even sure how many studies are done to show this, but I think the textbook said it, so I put it in there. Again, there's not really any difference on your labs for OA, but we do want to keep an eye on your other markers. Just keep an eye on the rest of your organs. And I guess part of that is because kidney disease is more common in people with RA. You know what? Look that up. Just double check on it for me. I wouldn't worry a whole ton about that. I can't imagine that's going to be a question on the exam. And so what do we do for osteoarthritis? So a lot of this is just about inflammation and pain management, preventing like further degradation, so that we want to maintain that range of motion as much as we can. A lot of times we do that by using heat. This splinting here is it seems kind of like, why would we splint the joint? But so it actually keeps the joint in like a functional position to avoid it kind of settling in a dysfunctional position. But again, we do not want that to be, we would never do that for too long, right? Sorry, I just heard a little bing. So clear yellow synovial. No, so clear and yellowish synovial fluid is the normal color. So synovial fluid is normally clearish, yellowish, but not yellow or brown or green. Those are the colors you really want to watch out for. If it says clear before the color, clearish or clear yellow, you're fine. It's if it says it's yellow or it's green or it's brown. Okay. Where was I? Okay, awesome, no problem. Any other questions, just make sure you stick them in the chat and I'll get to them. So most interventions for OA are non-pharmacological, with like drug therapies on the side. Again, we're balancing these periods of rest and for joint protection, and then using assistive devices can be very helpful because we want to decrease the stress on those joints. This is especially true for osteoarthritis of the knees. Want to avoid prolonged standing, kneeling, which has 2 E's, and squatting. So movement therapy just means we want to keep, so at the same time as we want to rest, we still want to keep using the joints. And things like yoga and Tai Chi are great for this because they're kind of slow movements, right? They're not anything that's jarring or putting a lot of pressure on those joints. So keeping strength training and aerobic fitness, but we don't want to jar those joints too much, right? And then, oh my gosh, this question comes up. Appropriate footwear is huge. And we want to work with our PT, OT. They're part of the team. So physical therapists, occupational therapists are really, really big when it comes to kind of treating OA and OA symptoms. There are some things that we can do. Your slides really highlighted acupuncture, sorry, so I threw this in here because I do think there was a whole slide on it, so this is something you just might want to know a little bit about, knowing that it is used for treatment of OA, kind of knowing what it is a little bit, and that it can be an effective treatment. So if you end up with a question asking about, oh, the patient says they're using acupuncture, the answer isn't, oh, acupuncture doesn't work, or some such answer. Like, it actually is part of is considered an effective therapy, just so you know, because I know some people get tricked up on that question. And then some of the other things we can do, for example, if you have, a grade 4 osteoarthritis of the knee, they could do a total knee arthroplasty. Same with the hip. Usually this happens when somebody is older, like not older, but older than 65. It doesn't often happen to 20-year-olds, and obese. So we've put so much pressure on those two joints. And so what they will do is actually just completely replace the joint. Obviously that's a major invasive thing to have done. So we want to try to avoid getting there if we can. Just in case they ask you anything about after an arthroplasty, so if somebody's had a hip replacement, we don't do any extreme like internal rotation or more than 90-degree hip flexion for 4 to 6 weeks. So we use assistive devices. There's like a foam abduction pillow, but we don't want to over rotate the hip more than 90 degrees. Just kind of keep that in the back of your mind. It wasn't in your notes, but it tends to come up here and there. And then we have our awesome pharmacological treatments. So you've got your Tylenol or acetaminophen, NSAIDs. Antibiotics is just likely just if there's an accompanying infection. These are so intra-articular. These injections, and I actually get this corticosteroid injection done. These are they're directly into the joint. So for example, if we inject corticosteroid right into the joint, it's going to work. We're going to talk over here about how but it's going to work right in that place. Corticosteroids often work not just work better when we use them locally, I think, but they have less systemic side effects, because I think we've talked about this before, but well, maybe not in this class because you guys are new to me, but corticosteroids have like a bazillion side effects. We try not to give them unless we like absolutely have to. And then this is really just the big, what's great about these cyclooxygenase inhibitors is it's kind of applicable to last week and this week. So I didn't want to overwhelm you by putting it on last week. I thought it was, it was so much information, and I know this week is a little lighter, so I thought let's put it here. So we did kind of go through this whole cyclooxygenase pathway, correct? So we talked about how this bilayer of phospholipids breaks down using this phospholipase A to breaks down into arachidonic acid. This was part of our inflammatory stuff last week. And so this is where those corticosteroids work. They block the synthesis of that enzyme so that this phospholipids cannot be broken down into arachidonic acid, because if you follow the whole pathway down, you end up with really, I'm not worried about thromboxane right now for this. We're worried about these prostaglandins, because prostaglandins are responsible for a large portion of inflammation and pain. Remember, I said you need prostaglandins and bradykinins to have pain. And so this medication, for example, corticosteroids, working right here, is going to do a lot to prevent that prostaglandin from being synthesized, or from the phospholipids breaking down into prostaglandin. The problem is those corticosteroids have so many side effects, so we try to avoid that. So what we use now more is, you guys give a ton of this, I'm sure, like ibuprofen, naproxen, Celebrex, and these NSAIDs. So NSAIDs, obviously, it stands for non-steroidal anti-inflammatory. So it's not one of these, right? Problem is they work in a different place. And so you can see as we go down here, we've talked about this. There's this COX-1 enzyme that works over here, and there's this COX-2 enzyme that works over here. Both of them work to break up arachidonic acid into prostaglandin. I really like how Christine explained this, I think, in one of her slides, by calling COX-1 the good COX and COX-2 the bad COX. I've never heard it explained like that before, but it's very helpful. So if you can remember that, COX-1 keeps your GI lining intact. It's good. This is a good enzyme. And so when we block this enzyme, we end up with gastric erosion and ulceration and GI bleeding, because COX-1 actually keeps the GI lining intact. We'll talk about renal impairment and platelet aggregation in a second. So if we look over here to this enzyme, if we consider this the bad one, then when we inhibit it, we're basically inhibiting the creation of this prostaglandin, which inhibits, or just means there's a decrease in inflammation and a decrease in pain and fever. Over here, you're going to have that same decrease in inflammation and pain, but you're going to have these other things as well. Now, regardless of whether you you inhibit COX-1 or COX-2, these NSAIDs or NSAIDs are very hard on your renal system. So no matter what, we're very cautious in giving a lot of NSAIDs to somebody who has acute kidney disease or chronic kidney disease, or actually my son only has one kidney, and so we don't give him a lot of NSAIDs, as we don't want to damage the remaining kidney, right? So that's this whole renal impairment thing, really important to remember for NSAIDs. And the other thing is that this, I just want to make sure I'm here. So we're decreasing renal function, right? Which increases, I think in a few weeks we're going to go over kidney function, so you'll understand this a little bit better, but it's going to increase your blood pressure and your edema, and then you're increasing your risk of MI and stroke. Now, this isn't like a huge risk for for COX-1, but this is a very big risk of your COX-2 inhibitor, and your main one here would be Celebrex. So we'll just go over here because I'll look at the actual. I just kind of wanted to go through, okay, this is how they work, and then you can see here, if you look at these little dots next to the medication, it'll tell you whether it's a COX-1 inhibitor or COX-2 inhibitor. Okay, so originally we had aspirin, or ASA, and it worked to block COX-1. It worked on inflammation and pain and fever. COX-1 is, ASA or aspirin, also decreases platelet aggregation, so it stops the platelets from sticking together, which means it will have a good effect on clots, right? It prevents clots from building, and so taking aspirin, and we know that aspirin will it has an anticoagulant effect, so it will protect from MI and stroke. The problem is on the side of that, because we're blocking that good COX or whatever, we are going to deal with this GI bleeding and ulceration. And so when you mix anticoagulant together with GI bleeding and ulceration, we just have to keep an eye on that. And you all know that we all give aspirin, and we're definitely cautious in patients with histories of GI bleeds, right? So this will, and yes, it's nephrotoxic, okay? All the first line, they're all nephrotoxic, right? So this was kind of the first line anti-inflammatory that led to the development of these other anti-inflammatories. So your ibuprofen, naproxen, Voltaren or diclofenac, Toradol. Those are all COX-1 inhibitors. I'm going to talk about Tylenol in just a minute. I have like a different kind of file for it. And then the only really COX-2 inhibitor are these Vioxx, which I think is only American, so you don't need to worry about it. And here it's really just Celebrex. I don't know how long ago it came out, but I remember when the study started coming out showing that it had such a high risk for MI and stroke. And so people were really, really concerned and getting pulled off of this medication, because they're on, you're on an NSAID for osteoarthritis. You really don't want that to cause, an MI or a stroke. So while Celebrex doesn't have that same effect on your GI system, there isn't kind of that risk where you have over here with the GI ulceration and bleeding. If you take it with an anticoagulant, that will increase kind of that risk that the anticoagulant has of causing a GI bleed. So, in terms of like your exam, really remembering about Celebrex is this high risk of MI and stroke, but that it gives you the anti-inflammatory results that you want without this the GI problems that you have with a COX-1 inhibitor. Okay, and then Tylenol, pretty simple stuff. The exact mechanism of action is unknown, but let's go down here because I made this little kind of comparison here. Really, the important thing that you need to remember for your exam is that Tylenol has no anti-inflammatory properties. And I know that you guys know that, but it's definitely something that will pop up. Well, I think it'll pop up on this exam for you guys. So just remember that. So your NSAIDs will have the anti-inflammatory. They have the risk of GI ulceration. So, and they have that inhibit the platelet aggregation, which means they have those anticoagulant properties. And then they're nephrotoxic, which we just talked about all of that. I'm just kind of reading it through. So we've already talked through all of it. But with Tylenol, it inhibits prostaglandin synthesis in the CNS, not the periphery. And so it doesn't have really any of those side effects. The only thing you need to worry about, now it doesn't have the same anti-inflammatory property either, so you need to remember that. But the only thing you really need to worry about with Tylenol is damage to the liver. And that they're coming out with more and more studies that are showing how hepatotoxic Tylenol actually is, but as long as you stay under 4,000 milligrams a day, your risk of anything or like harm to your liver is limited, right? The only time, so this is a good thing to remember, that chronic alcohol use will exacerbate this hepatotoxicity, but only if you take too much Tylenol. So if you're a chronic chronic drinker and you take Tylenol, as long as you stay under that 4 grams or 4 milligrams a day, it's not going to make a difference. But if you do overdose or take too much Tylenol in a day, then that alcohol, that is going to have that kind of synergistic effect, and you will end up doing a lot of damage to your liver. So, and I just put this is part of like the drug book when it talks about Tylenol, but we all know that, like, I don't think anybody considers that really in real life, that it may inhibit the metabolism of warfarin, but just in case it pops up on your exam, I wanted to kind of stick it in there. And then I think that's it. So like I said, it's really, really, really not a heavy unit this week. There's a little bit of stuff that kind of, this stuff especially, that will kind of like go along with what we took last week, or what we did last week. But if you're focusing on, when you're studying, if you're focusing on, if you end up studying and you feel like you're not studying a whole lot of this, that's because there isn't a whole lot of content. So don't freak out. Focus on the inflammation and hypertension. And again, I'll make a study note for you guys if I can get to it. Does anyone have any questions before we sign off? Any questions about like what we talked about today? Or I don't know, any questions? I'm actually going to just click off the recording. So if you do have questions.